to elevate your expertise in the resuscitation and emergency medicine field. Welcome to the Resuscitation and Emergency Medicine Diploma, a premier one-year online program designed to equip you with advanced knowledge in the resuscitation and emergency medicine field. Our aim is to provide you with high-quality educational materials and up-to-date resuscitation and emergency medicine scientific knowledge, delivered by a panel of highly qualified international expertise. Our professional panel ensures that the curriculum is high quality, up-to-date, evidence-based, and well-structured. Why travel for training when you can learn from top resuscitation and emergency medicine experts online? Our program brings world-class instruction directly to you, no matter where you're located. Through case-based discussions, Q&A sessions, virtual workshops, and personalized feedback, you will receive the high-quality education that is going to augment and complement your in-person program, all from the comfort of your home or workplace. Our Resuscitation and Emergency Medicine program offers a comprehensive diploma structured into 3 modules, 16 weeks each, with a total of 96 credit hours and in-depth training over 1 year period. Balancing work, life, and professional development can be challenging. Our Resuscitation and Emergency Medicine Diploma is designed with your busy schedule in mind. With self-paced learning modules and live virtual sessions, you can advance your skills without disrupting your clinical duties. This program allows you to learn and gain experience at your own pace. From mastering basic and advanced life support to specialized training in airway and mechanical ventilator management, to advanced trauma and burn life support, ECG interpretation, and arrhythmia management and ER radiology, orthopedics, toxicology, pediatric, and obs-and-gyn emergencies, and ER procedures, you will develop the essential skills to manage ER patients at any circumstances and healthcare setting. Upon completion, you'll earn an internationally recognized American Association of Continuing Medical Education accredited graduation certificate, helping you enhance your credentials, advance your career, and improve your patient outcomes. Join a growing community of EM professionals who have transformed their careers with this diploma. Don't miss this opportunity. Visit our program landing page and register to reserve your spot. Limited seats available. Don't miss your chance and register today.
Hello, everyone, and welcome to our Resuscitation and Emergency Medicine Diploma webinar. Today, we have a very special webinar and also very special guest speakers, and we are focusing on emergency medicine in action, mastering critical decisions in emergency medicine. Very, very important and pivotal 3 presentations that we're going to discuss on 3 topics. And our speakers are Dr. Nesreen Bazarbash from Turkey, and Dr. Hind Mansour and Dr. Muhammad Nasruddin from Egypt, and our great moderators, Dr. Hakim Al-Kholi from Egypt and Dr. Amjad Makhur from Lebanon. And here is our humble agenda today. So after this brief introduction, Dr. Nesreen Bazarbashi is going to give about a 19-minute talk, and sepsis in emergency medicine. It will be a case-based discussion. Then Dr. Hind is going to give us a very nice lecture about ABG interpretation. Then Dr. Mohammed Nasruddin will give us about 20-minute talk about ECG and acute coronary syndrome beyond the non-STEMI. So three very important topics today, and Dr. Hakim El-Khouly and Dr. Amjad Makhur are going to help us to moderate the session and try to answer the questions. So again, great speakers, Dr. Nizreen from Turkey, Dr. Hind from Egypt, and Dr. Mohammed Nasruddin, who was appointed as assistant professor at Tanta University, so congrats. Dr. Hakim El-Khouly, and he is a fellow of American College of Surgeon, ENT chief, Region 7, and he is the director of the Egyptian Resuscitation Association. Dr. Amjad Makhur is emergency medicine consultant in Lebanon. Just a couple of housekeeping stuff here. If you have any question, inquiries, please feel free to type it in the QA box. All attendees should receive a certificate of attendance by next week, and you all should get the YouTube link of the recorded webinar by tomorrow. If you want not only to see the slides, but to hear the presentation with your own language, you can always enable or show the caption option so you can see the transcription. So I just want to emphasize that this knowledge that we are offering has no value until we put it into our clinical practice to improve our patients' outcome, because the great aim of education is not the knowledge, but the action. And with that, I'm going to let Dr. Nizreen to give us her very nice presentation, how to deal with sepsis in the emergency department. That's a very important topic, and the lecture is going to start soon.
Good evening, everyone. I'm very glad to be with you today to address a topic that is particularly close to my heart, sepsis and septic shock. Sepsis represents one of those critical emergency department presentations when and where timely, targeted intervention can fundamentally alter a patient's clinical outcome. I'm Dr. Nasreen Bazarbashi, Head of Emergency Department at Haikal Hospital and Chair of the Emergency Medicine Program at the University of Element. So, our objectives for today are to revisit the clinical definition of sepsis and septic shock, evaluate current screening tools, review traditional management bundles alongside with the 26 updates, and translate these guidelines into an actionable, practical ER clinical pathway. So the modern sepsis care must remain fast, but it should be individualized, reassessed, and evidence anchored. We have to recognize, treat, resuscitate, reassess, and de-escalate our management. To set the stage, let us begin with our first clinical case. So we have a 74-year-old man brought to the emergency department by his wife because of fever, confusion, and progressive weakness over the past 24 hours. The wife reports that he complained of dysuria and urinary frequency for the last 3 days. In his medical history, we found hypertension, type 2 diabetes, chronic kidney disease stage 3, and heart failure, but with preserved ejection fraction. The vitals, as you can see, we have a high temperature, an elevated heart rate, a blood pressure around 8/4, so a MAP of 58. The respiratory rate is 32, and we have a good saturation, and the Glasgow score is 14. The physical examination reveals that the patient is confused but arousable. He has warm extremities, a capillary refill of 4 seconds. He has mild bilateral ankle edema, no obvious pulmonary crackles. The lab tests are as present. The lactate is around 5, an elevated count of YBC, elevated creatinine 2.3 with a baseline of 1.4. The bilirubin is normal, and the urine analysis reveals positive nitrite with a high count of YBC. So for this patient, which statements best describe this patient condition? You can all guess the patient is suffering from a septic shock. Sepsis versus septic shock. While in the sepsis we have an infection plus a life-threatening organ dysfunction, the septic shock is a high mortality subgroup of sepsis. We have yearly around 11 million deaths due to septic shock worldwide. So the septic shock is a vasopressor requirement to maintain a MAP more or equal to 65, plus an elevated lactate level in the blood, and this despite adequate fluids. Of course, the hypotension alone is not enough to mean that our patient is suffering from a septic shock. The septic shock reflects a persistent circulatory and metabolic failure and the presence of high lactate in his definition. So, in front of recognition, we must trigger parallel action, taking culture, starting antimicrobial fluids and vasopressor, and of course, the control of the source of infection. Now, let us review the evolution of our diagnostic definitions. Looking back from the early consensus criteria in 1991 to our current framework. In 1991, sepsis 1, defined by a consensus panel by the American College of Chest Physicians and the Society of the Critical Care, the definition was based initially upon a 4-stage spectrum ranging from SIRS to septic shock. In 2001, the sepsis moved to a 2-stage spectrum, sepsis and severe sepsis. This sepsis incorporated a broader array of clinical and laboratory diagnostic parameters like the CRP, the procalcitonin, the oliguria, the thrombocytopenia, and the lactic acid. The sepsis 3 classification in 2016 streamlined into 2 distinct clinical entities: sepsis, infection with SOFA score more or equal than 2, and the septic shock is a sepsis with persistent hypotension requiring vasopressor to maintain a MAP more or equal than 65 plus a lactate level more than 2. For the patient with a long stay in the ICU, they introduced the Q-SOFA. It's a bedside measuring of the blood pressure, the Glasgow score, and the respiratory rate. The Q-SOFA should not be regarded as a diagnostic criteria. It's a warning for patients with suspected infection and a criteria for a poor outcome. After the SIRS, let's see the SOFA score. According to the sepsis 3, acute increase more than 2 or equal than 2 from baseline suggests sepsis in a suspected infection. So we have respiratory rate, the coagulopathy, the liver function, cardiovascular function, the nervous system, and the renal output. The calculation goes from 0 to a total of 24, and of course, when we are measuring one of the vitals, we take the worst value during the observed period. Let's put all these screening tools together. Which definition is the best? Many articles and studies compared the clinical usage of sepsis 1 versus sepsis 3 definition. The QSOFA has a poor sensitivity, it has a high specificity, it's a predictor of mortality. The SIRS criteria are highly sensitive but has a low specificity. The severe sepsis in sepsis 1 definition is more likely to be more sensitive than the QSOFA and more specific than the SIRS. QSOFA is not for screening. We should use clinical judgment plus clinical parameters like in NEWS, NEWS2 or MUSE, and organ dysfunction markers. We should not wait for a score before treating a clinically obvious septic shock in our ER department. Let's go back to our 74-year-old man presenting to the ER for a septic shock. Which intervention should be initiated immediately? Of course, we should start the application of our local bundle, obtain culture, administer broad-spectrum antibiotic, begin our fluid resuscitation plan, and monitor the tissue perfusion. We all have our traditional gold standard sepsis bundle in our ER. We measure and remeasure the lactate if elevated. We obtain our blood culture before antibiotics when feasible, of course. We administered our broad-spectrum antibiotic. We give 30 ml per kilo of crystalloid for hypertension patient or hypoperfusion, and we start norepinephrine only if the MAP remains less than 65 after the fluids. Do we need to change anything in our traditional bundle? We'll go back again to our patient. He weighs 80 kilos. Which initial fluid strategy is the most consistent with current recommendations? For our 74-year-old man, suffering from a heart failure, according to the new recommendations, we should start with a bolus of 250 to 500 crystalloid and reassess the fluid responsiveness. What would change in our modern sepsis bundle? Recognition. Do the ABC secure an IV or IO access? Measure the lactate and organ dysfunction marker, but do not delay the treatment. Culture, blood, and other culture, yes, but if it does not delay the treatment, start the antibiotic according to probability and shock status, and this within a 1-hour bundle. Use, of course, the crystalloid boluses and introduce the early norepinephrine when appropriate. The reassessment should be done dynamically and not statically anymore. Hypertension patient, we start our boluses. We target a MAP of 65 for most adult. For patients older than 65, a MAP of 60 is allowed. We use peripheral line for norepinephrine. When others vasopressors are to be used, it's preferable to pass to a central line. To our patient again, after receiving 300 ml of balanced crystalloid, the patient MAP remained 57. A focused POCUS examination shows a hyperdynamic LV, no RV dilatation, bilateral A lines, no B lines on the lung, and the diameter of the IVC is 1.2 centimeters, marked by a collapse in the inspiratory time. The passive leg raise show a stroke volume variation less than 7%, but the best interpretation of this patient. As we dynamically reassess the fluid responsiveness of the patient, we can see clearly that the patient is still fluid responsive. Our patient has now received a total of 800 ml of balanced crystalloid. His blood pressure remains low with a MAP of 59. A repeat POCUS examination demonstrates that the LV is no longer underfilled. The IVC diameter is now 2 centimeters with minimal respiratory variation. New bilateral anterior B lines are present, and the passive leg raise results in only 8% increase in stroke volume. What is the most appropriate next step for this patient? Despite the fact that the passive leg raise result in only 8% increase in stroke volume, the patient is becoming overloaded. He will start developing a pulmonary edema, so will not be administrating more fluid to this patient, but will be starting the norepinephrine while continuing for sure the antibiotics, the source control, and the serial hemodynamic reassessment of the shock. First comparison, old bundle, new bundle, complete fluids, then norepinephrine. The new one, small boluses plus early norepinephrine plus repeated assessment. Despite the fact that the studies couldn't demonstrate a clear benefit on the mortality, the recommendations of the 2026 sepsis campaign remains clear about taking into consideration the benefits versus the harms that a large amount of fluid can cause to our patient. So avoid repeated boluses just because lactate remains elevated. The target is not the normalization of the lactate anymore. The assessment of the fluid responsiveness should not be static. We used the POCUS ultrasound to assess the responsiveness. By using the IVC ultrasound, it's useful but not alone. The IVC interpretation is affected by many components like the breathing, the ventilation, the tidal volume, the pulmonary hypertension, the interabdominal pressure. One better approach should be taking into consideration many other measures than the IVC, like the heart, the lungs, the venous congestion, and the dynamic response. When possible, the measure of the stroke volume and the variation of the stroke volume, the passive leg raise, or the mini fluid challenges could be used in one algorithm to assess the responsiveness of a fluid strategy for our patients. POCUS ultrasound has a big role helping us phenotyping our patient. Vasoplegia, real hypovolemia, LV dysfunction, RV failure, or mixed shock. So the goal is to identify the hemodynamic phenotype and tailor the fluids strategy, the usage of vasopressor, inotrope, and of course, helping sometimes to find the source of infection. Let's go back to our bundle again. We recognized our sepsis or septic shock. We should start our antibiotic. Antibiotics, fast but not blind. Culture should be taken without delaying the administration of the antibiotic. A bundle of 1 hour should be initiated for the septic shock patient. The antibiotic, the choice of the antibiotic should reflect the match of the source, the severity, the local resistance, the prior culture of the patient. So sometimes it's very useful to consult the previous admission of the same patient, the risk factor, of course, and the host factors. Using lactam as a first dose, it's preferable to use a full loading dose, then continue with prolonged or continuous dosage in the ICU stay. So to summarize, what has changed? Fluids, yes, by boluses, and reassessment regularly. Early introduction of norepinephrine when hypotension persists. Responsiveness should be assessed dynamically. using multimodal perfusion like capillary refill time, urine output, mentation, lactate, and the usage dynamically of the POCUS ultrasound. The administration of beta-lactam by loading dose and then prolonged maintenance infusion, de-escalation and shorten the duration of the administration of antibiotic, and of course the source control. Let's conclude by some take-home messages. Sepsis remains a problem in our ER department. It should be recognized because it's associated with life-threatening organ dysfunction. Antibiotic and source control remain central. Norepinephrine should not be delayed to finish our 30 ml per kilos of balanced crystalloid. Fluid should be indicated, driven, and dynamically reassessed. IVC alone is not anymore a fluid prescription tool. It should be integrated in a whole bundle of reassessment driven by POCUS ultrasound like lungs, heart, and dynamic tools like leg raise, stroke volume variation. Beta-lactam should be administered initially by loading dose, then prolonged maintenance infusion when appropriate. For the antibiotic courses, they should be shorter, culture-guided, and source-controlled. Modern sepsis care, it's rapid, but should be more and more personalized to our patient status. If I have one advice to give you, create your own bundle in your own ER department and train your people enough so they can recognize every single sepsis presenting to the ED. For your attention, and I hope you enjoyed the presentation.
Thank you so much, Dr. Nazreen, for this very nice illustrative presentation. So Dr. Nazreen is a consultant, and she is the CEO of the Haikal Hospital and the former president of Lebanese Society of Emergency Medicine. So great lecture. We have a couple-minute presentation description about our upcoming resuscitation and emergency medicine diploma. Then we'll do Dr. Hand presentation right after that. So stay tuned. Hello, everyone, and welcome to our World Institute Critical Care and Emergency Medicine Resuscitation and Emergency Medicine Diploma, which is very unique flagship program for 1 year, focusing on the basics and advanced knowledge in resuscitation and emergency medicine. And we have gathered international expertise from all over the world to help you to understand the foundation and the novel techniques and clinical knowledge in resuscitation and emergency medicine. This is not based on monologues or lectures, but based on bidirectional education with dialogues and engagement of our fellows throughout live sessions, clinical case scenarios, MCQs, and journal clubs. Because we know that your retention rate is very low when it comes to giving you lectures or giving you materials to read, we try to involve you throughout the whole year of this diploma, doing demonstration, having discussion, and trying to apply this clinical knowledge into your clinical practice, and also helping you to teach others this knowledge to have the best retention rate. So all of our fellows in this program are going to receive very high quality scientific materials on weekly basis, and they have to turn on their assignments and tasks before the end of each week. And all of their activities are monitored in the SMART platform. So each of them will have a username and password, and will have access 24/7 to our high quality educational materials. So our one of the major aim of this diploma is to identify our fellows' weaknesses and to work on it and to empower and enlighten their strength. Again, we are aiming to let you to master the clinical practice and the training in resuscitation and emergency medicine throughout a smart e-learning process. And mastery doesn't come only with the basic knowledge, but it comes when you apply clinical knowledge into your practice. So it's 100% online program accredited by the American Association of Continuing Medical Education with 96 credit hours and structured as 3 modules, 16 weeks each. Module 1 is focusing on resuscitation and life support. Module 2 will be focusing on core emergency medicine topics, and Module 3 will have advanced practice and procedures. Again, it's 1 year program, and it has every week new case-based discussions, MCQs, clinically based, and clinical scenario journal club, and also will have live webinars. Again, it's accredited for 96 credit hour by the American Association of Continuing Medical Education. And upon completion of this diploma, you will be graduated to a trainer and the mentor level in the emergency medicine field. So please join our growing community of emergency medicine physicians who are going to help their patients and hopefully improve their outcome. If you want to join, if you are interested, please feel free to join, and you can get 10% discount using the promo code of webinar 10. So this is going to expire soon, so please try to apply as early as possible and take advantage on this discount. Again, knowledge has no value until we put it into practice, and our aim from this educational program is not the knowledge itself, but the action. We are helping you to improve your clinical practice and your patient's outcome. With that, our next speaker is one of the founders of this fellowship and diploma, Dr. Hind Mansour. She's a lecturer and emergency medicine consultant. She's originally from Egypt and now works in King's College Hospital in Jeddah. She is going to give us a very nice demonstration how to interpret EPG in the emergency medicine department with a practical step-by-step approach.
You all can see it clear? My voice is clear? Hi everyone, it's Hind Mansour, emergency medicine consultant, and today our goal is to know that the BH can lie or not. A normal BH walks into your resus room and then it looks fine, but it's lying. So tonight we will catch it. So by the end, we will be able to recognize the 4 primary disorders, apply the 5-step approach, calculate an ion gap, test for compensation, using the delta relationship cautiously, and finally integrate numbers with the story. So normal BH is not a normal patient. A normal BH can hide 2 or even 3 serious acid-base disorders occurring at the same time, which is only the final score. The real story is hidden in the numbers behind it. So let's start with normal blood gas and see how this normal BH can fool us. So in the beginning, we have to know that pH normal value is 7.35 to 7.45, and for carbon dioxide, it's from 35 to 45 millimeter mercury, and for bicarb, it's from 22 to 26 milliequivalent per liter. And for anion gap, we all use this local lab range according to your hospital, but it's about 12 in most of hospitals, milliequivalent per liter. And to know if pH is more than 7.45, so it's alkalosis, and if it's less than 7.35, so it's acidosis, okay? So you have to name the direction before you name the disease. So you have to know your direction before you go for the PPG analysis. Um, you have to know also that down takes us to acidosis and up takes us toward alkalosis. So if bicarb is the primary move, think metabolic. And if the carbon dioxide is the primary move, you have to think respiratory. But there is a catch. Lung can only have one carbon dioxide change at a time, while metabolic process can coexist. That tiny rule becomes extremely important when we reach fourth triple disorders. So if you had low pH and bicarb is low, so it's primary metabolic acidosis. If you have low pH and carbon dioxide is increased, so it's respiratory acidosis. Have if you have pH increased and carbon dioxide decreased, so it's primary respiratory alkalosis and so on. Okay. So we go for the 5-step acid-base approach. You need a system because acid-base interpretation shouldn't be by intuition. Every blood gas you run, you should go through the whole 5 steps, whole 5 questions, which are: what is the pH doing? Is it acidemia or alkalemia or near normal? What is the primary process? Which variable explain the pH direction? Is it respiratory or metabolic? Is there an ion gap? We will know how to calculate an ion gap. And then is there compensation? And then we go finally to the delta gap, which reveal another metabolic disorder. And we only measure delta gap if there is a high anion gap metabolic acidosis. If you follow those 5 steps every single time, a triple disorder stops looking complicated. It becomes something you can uncover layer by layer. So we need to know that compensation is predictable. And we have some diagnostic tools to get the expected responses. So if you have metabolic acidosis, there will be respiratory compensation. Your body will hyperventilate to wash out carbon dioxide and increase pH. So we use one formula called Winter's formula. There is a lot of equations, but I prefer this one because it's easy. When you get to know what is the expected carbon dioxide, you multiply 1.5 by bicarb plus 8 plus or minus 2. Then you get the expected carbon dioxide. Then in case of metabolic alkalosis, there will be also respiratory compensation. Your body will try to retain carbon dioxide to pull pH down. And by the way, this is the hardest compensatory mechanism for the body to perform. Okay? And then for respiratory and for acute respiratory acid-base disorder, you can have acute and chronic. Why? Because metabolic compensation takes time already. So you will have acute compensation and chronic compensation. So in case of acute respiratory acidosis, bicarb will increase 1 millimeter mercury per each 10 millimeter mercury rise of carbon dioxide beyond 40. And we have this simple rule. It's 1, 2, 4, 5. Okay? In all 4 respiratory rows, bicarb change per 10 millimeter mercury of carbon dioxide change above or below 40 millimeter mercury. Okay, this rule will make it easy for you. So our rule of thumb will be compensation is never overcorrecting. Bicarb and carbon dioxide always go in the same direction. If not, you have to think of mixed disorder. Metabolic compensation takes time, so we will find acute and chronic. And for the body to lose is more easy than to retain. Okay? So if the measured carbon dioxide below expected, in case of metabolic acidosis, it means there is additional respiratory alkalosis. If measured carbon dioxide above expected, okay, so we have additional respiratory acidosis. Now we get to measure the anion gap. Elevated anion gap means unmeasured anions are in your bloodstream, accumulating with common causes like ketoacidosis, like lactate accumulation, chronic kidney disease, etc. If the patient has low albumin, also you have to measure adjusted anion gap. So how we measure anion gap? It equals sodium minus chloride plus bicarb. And if my patient is let's say a chronic liver disease, has low albumin for any other reason, you have to measure the adjusted anion gap. Because as low albumin can lower the observed anion gap and mask high anion gap metabolic acidosis. So we use this equation: adjusted anion gap equals measured anion gap plus 2.5 by 4 minus albumin measured in gram per deciliter. So elevated anion gap means unmeasured anion are accumulating. Then we go for the delta toolkit. Finally we get to the delta gap. We calculate it only when there is high anion gap metabolic acidosis. Why? To check if there is another hidden metabolic process. Okay? يعني we measure delta gap only in case of high anion gap metabolic acidosis. طيب, how we measure delta gap? This delta gap equals delta anion gap divided by delta bicarb. طيب, how we measure delta anion gap? Delta anion gap equals measured anion gap minus 12. طيب, how we measure delta bicarb? Delta bicarb equals 24 minus measured bicarb. Then we get delta anion gap, delta bicarb, and divide this. We will get the result. Result should equal 1 or 2. There is another way to measure it, but I don't like to use يعني. Okay. يلا, let's start. I need from every one of you to have a mobile to scan the code. And by the way, I will never know who answered wrong, who answered right. It doesn't matter, but it's an easy way to participate in a very nice way. So please all participate. Okay. So you have 24 years old male with type 1 diabetes presented with vomiting, and you have the following VBG. Your pH is 7.25, carbon dioxide 27, bicarb 12, sodium 138, and chloride 100. What do you think? Yeah, you have 1 minute. Follow the 5 process we just said. Wow. How many one answered? Nice.
Now the split between high anion gap metabolic acidosis and high anion gap with appropriate respiratory compensation, but more for option A, high anion gap metabolic acidosis.
Plus, no one more will participate. I go?
Yeah.
Thank you.
90% with option
Okay. Okay, that's right. It's isolated high anion gap metabolic acidosis with appropriate compensation. So if you follow the steps, our pH was low, and then we checked is it because of respiratory or metabolic. So it's metabolic acidosis. Then we check their high anion gap or no. We measure anion gap. Anion gap is elevated, so it's a high anion gap metabolic acidosis. Then after we measure high anion gap metabolic, we check for compensation. In case of metabolic acidosis, we check expected carbon dioxide. So it's within expected range. So it's a high anion gap metabolic acidosis with appropriate respiratory compensation. Thank you all for participating. Yalla, next case. You have patient with severe ketoacidosis, becomes drowsy after sedative and develops shallow breathing. Same one in the previous case. His pH is 7.1, carbon dioxide 40, and bicarb is 12. Okay. Now, carbon dioxide is 40. Is it normal or dangerous in this patient? Yalla, let's see. Is there superimposed disorder or no new disorder? Great. There is superimposed disorder. What happened if we follow also the same steps? We had high anion gap metabolic acidosis and measured it already. Okay. And then when you go now for the compensation, you do Winter's expected formula. You found that expected carbon dioxide supposed to be 24 to 28. But now this carbon dioxide in our VBG is 40. So there is another issue is happening. Another thing is cooking. There is superimposed respiratory acidosis, either due to ventilatory failure or suppression that prevent compensatory hypocapnia or whatever happened. So if you saw normal value, it doesn't mean that's normal in that patient. Thank you all. Yeah, next one. In this patient with diabetic ketoacidosis and the profuse diarrhea, you have this VBG. pH is 7.18, carbon dioxide is 24, bicarb is 10, sodium is 138, chloride is 112. So I already told you it's high anion gap. I told you one answer. I need to follow those three equations. How do you calculate anion gap? Is the expected compensation enough, or is there is superimposed disorder? And then we will go for delta gap. Yalla, what's the order now? Is it high anion gap metabolic acidosis, normal anion gap metabolic acidosis, high anion gap metabolic acidosis plus normal anion gap metabolic acidosis plus inappropriate respiratory compensation, or what else? 50-50. Okay. Anyone else? Hmm. I know those people, when they find the high percentage for one answer, they go for it.
It's again a split between A and B, but majority
It's
is for
okay.
A.
So it's this case is two metabolic acidosis and one with one low bicarb. So if you measure the anion gap, you will find the high anion gap metabolic acidosis, and then if you measure the compensation, you will find it's within expected range. Then for the delta ratio, you will find there is also normal anion gap metabolic acidosis. So I know we are way behind. This one is the latest one. Yalla. Perfect storm walks into the ED. 56 years old man with chronic heavy alcohol use, poor oral intake, 3 days of persistent vomiting. Last 24 hours he had fever, productive cough, breathlessness, dry mucous membranes, and poor intake. Okay, and that's his BBG. Wow, you look at the pH, it's normal, so it's okay. Uh, I think this guy is doing well. He can survive. Okay. Don't diagnose from the pH alone. You have to run all the 5 steps. Yalla. This is the BBG of the patient. This is our last question. Then you will be relieved from me. I need you to participate. Yalla. Is it high anion gap plus metabolic alkalosis? Is it high anion gap plus metabolic alkalosis and respiratory acidosis? What is it? What do you think?
They like A, B, and
Mm,
C, they are equal now. So let's
yeah.
move on.
Yeah,
Okay.
let's move on. So I'm masking layer 1 and 2, this case, pH is near normal, but it's slightly acidic relative to 7.4. And then we will go to the primary direction. Bicarb is low, so it's metabolic acidosis. Then we measure anion gap. We find it's high anion gap metabolic acidosis. Then we check for compensation. You find that it's below expected. So in this case, we have high anion gap metabolic acidosis with respiratory alkalosis. Then we will go to reveal the concurrent metabolic alkalosis. You have to measure delta ratio. When we measure it, you will find that we have three disorders at the same time: high anion gap metabolic acidosis, metabolic alkalosis, and respiratory alkalosis. So rule of thumb, we treat the patient, not the pH. Any questions?
Thank you so much, Dr. Hand, for this very illustrative, informative, and thoughtful discussion and engagement. And our next speaker is Dr. Muhammad
Thank you.
Nasruddin. Thank you. Who is was just promoted for assistant professor at Tata University. He is emergency medicine, very well known physician and speaker, and he's going to talk about the ECG interpretation, focusing on not acute coronary syndrome, but other mimics.
Assalamu alaikum, Dr. Ashraf, Dr. Hind, Dr. Nasreen, and all our colleagues in that session. I hope that clear and screen and voice is completely clear for you all. So for the next few minutes in this session, I will try to discuss and highlight about the ECG used as a diagnostic tool in diagnosing acute coronary occlusion, and I will try to focus on its limitation point, the traditional STEMI paradigm. So during this session, sorry, I couldn't, yes, now it's moving. So I will try to rapidly review the formal and the standard definition of the STEMI according to the guidelines as we have been learned for a long time. And then I will try to discuss and focus on the limitation of that STEMI paradigm using real case scenarios. And finally, we'll give you a hint about the STEMI equivalence pattern that we are shifting now from the STEMI non-STEMI paradigm to the OMI non-OMI paradigm. So, as we all know, chest pain is one of the commonest ED complaints that we are facing almost every day in our practice. And ECG is still the most important single investigation in such patient, not only for diagnosis of acute coronary syndrome, which is the commonest cause by incidence, but it's also helpful in the diagnosing of other life-threatening causes like pulmonary embolism, pericardial effusion, aortic dissection, or perimyocarditis. So, as we know all from the assessment frame timing and the guidelines, ECG should be done in the first 10 minutes in the medical contact of the patient presenting to our ED with chest pain suspicious of acute coronary syndrome. So this is the condition. We have one patient in the triage, in the visual triage, clamping his chest, shouting from chest pain, and he will be directed directly to a high dependent zone, either recess or whatever, depending on your policy. And ECG will be done immediately with parallel with the vital signs for sure. And you will have one nurse chasing you, asking you to sign that ECG. So what's the most important thing when you are looking to this ECG? And according to this diagram, as we can see here in the first 10 minutes from the medical contact, the first question that should be answered is that if we are looking to a STEMI ECG, so the first thing is trying to rule out STEMI identification, and that will be directly using the ECG interpretation skills in combination with the rapid and focused history taking and examination. So our first question when you are looking for that ECG is I am looking to STEMI patient or not. And why STEMI in particular? We are not obsessed about the ST. It's not about the ST elevation. We are not treating the ST. We are not treating the ECG. We are treating the patient. But from our knowledge, from our pathology, and from our cardiology lessons, we know that STEMI means a complete coronary artery occlusion. So this is the most life-threatening, and this is the most critical extreme of the spectrum of the acute coronary syndrome. And its treatment is very sensitive, it's time sensitive. So if we are capable of doing primary PCI, that will be the first option, and all patients presenting within 12 hours of the STEMI. So we should transfer our patient directly to the cath lab, starting our procedure less than 90 minutes. And if we are not capable of doing the PCI in our center and we are transferring the patient to other center capable of doing that, it should be done within less than 120 minutes, I mean 2 hours. So this is the most critical diagnosis of acute coronary syndrome, and its treatment is really time sensitive. So what are the traditional STEMI definition that we have for now? And I will start, before going for the threshold, I will start with the condition for that diagnosing. So we should have our machine calibration at that standard one, 10 millimeter for 1 millivolt. So ST elevation should be measured at the J point, which is the first point in the ST segment. And that should be done in 2 contiguous leads at least. And what I mean by contiguous leads are that leads facing the same surface of the heart. So if we are looking for the inferior surface of the left ventricle, for example, contiguous leads will be lead 2, lead 3, and EVF. For example, for the lateral surface of the left ventricle, contiguous leads will be lead 1, AVL, and 5 and 6. And we are comparing that ST segment elevation in relation to the electric baseline, which is the TB segment. I mean the segment between 2 consecutive QRS complexes. And that interpretation should be done in the context of other causes that may be mimicking that ST deviation, like LVH, left ventricular hypertrophy, left bundle branch block, or pasteurism, that resulting in expected ST deviation. So these are the conditions before going for the threshold. So what about the threshold for the ST elevation? What are the significant ST elevation that should be considered? So in all leads, it depends actually on the lead, on the sex, and on the gender, yani on the age. Whatever the age, whatever the gender, in all leads, it's about more than 1 millimeter. This is the threshold. However, in female, for lead V and 3, V2 and V3 should be more than 1.5 millimeters. While in male, depending on the age. So if less than 40, it will be more than 2.5, while if more than 40, it will be 2 millimeter. So this is the short threshold we are using for defining significant ST elevation consistent with STEMI diagnosing. So for now, it seems clear and seems straightforward. So what's wrong with that STEMI definition, and what we are missing if we are sticking to that traditional long-lasting definition? Let's start with our cases for now, and I will need you to use your mobiles or whatever other device for voting. So this is the first one. Case 1, this is 45 years old female with acute epigastric pain. And here is her ECG. So take a rapid look over the all leads. In particular, let's say I will try to help you, the inferior leads, and then try to answer this question. Is that elevation, ST elevation seen in the inferior lead is consistent with the traditional ST elevation myocardial infarction criteria, yes or no? So again, I will show you the ECG in a minute, and then I will get back to the voting. So ST elevation, if you don't remember the threshold, again for all leads except V2 and V3, the ST elevation to be consistent should be more than 1 millimeter. Do you think in our previous ECG that ST elevation is for sure more than 1 millimeter? So the answer should be yes or no. And now it's about a relative majority for no. It's keeping going up and down. So I'll go forward. Now it's about 70% for no. And yes, this is clearly here. If we get the TB segment, and this is the TB segment, for example, and extend it up back through the ST segment, we will find that the ST segment could be a little bit isoelectric in lead 2. But if we looked in lead 3 and we get zoom in a little bit, we will find that ST elevation will be a little bit elevated. The J point should be out here is about less than 1 millimeter, less than actually half millimeter above the TB segment, and the same for EVF. So actually we have that ST elevation in the inferior lead, but actually it's not meeting that traditional STEMI criteria. But we have another significant finding. If we have a look over the lateral leads, lead 1 and lead EVL, in particular in this condition, which are representing the reciprocal leads, and we can see easily a ST depression. This is a clear ST depression in the reciprocal lateral leads. So this situation is already indicated in the text. If we have a look over this as 2022 ECC expert consensus on the diagnosis and the management of acute chest pain in the emergency department, we will find that clear statement that ST elevation less than 1 millimeter, particularly when combined with reciprocal ST depression, as this may represent abnormal coronary blood flow and vessel occlusion. And we can see also that concomitant reciprocal ST depression could be the only visual clear change that you can determine. However, this condition have the same outcome to the more extensive ST segment elevation. So it's not about the threshold. Don't stick all the time to the threshold looking for how millimeter is it the ST is above the baseline. It's not about the threshold per se. And sometimes the ST depression, the reciprocal ST depression, is the only clue that you can visually get. So please don't neglect EVL in that inferior subtle inferior STEMI. So outcome of this patient has a delayed angiography demonstrating 95% RCA occlusion. So this is a true acute coronary artery occlusion. And if you look back to the ECG, you can be easily fooled with the subtle ST elevation that not filling, you can be easily fooled by that subtle ST elevation that not fulfilling the traditional ST criteria. But again, please, don't overlook the lateral leads. Don't overlook, in particular, EVL. Don't neglect EVL in that condition, and don't stick to the threshold definition. So let's go for the second case. And this one is 47 years, male, medically free with central chest pain. And this is his initial ECG. I will get you for 1 minute to have a rapid look over that ECG. And the question will be, how would you classify this ECG? Is it true STEMI? Again, using the traditional STEMI definition that we have explained. Is it a true STEMI or it is non-STEMI case? So again, the majority for being non-STEMI, similar, I think, to the previous one. Looks like 70-30, 60-40, something like that. Now STEAM is getting back. So it's okay. Let's go from there. So again, the majority till now is saying that this is non-STEMI. And the difference between STEMI and non-STEMI is clearly obvious. If it's the STEMI, I will call for the cath lab, or I will send the patient to the other available cath lab, or I will start reperfusion if it's not available. For non-STEMI, I will start invasive clinical or medical treatment. So it's completely different when you are going for the next step. So what about we are looking for that patient? This patient, actually, there is no definite ST elevation can be seen here. There is clear ST depression in the anterior lead, starting from V2, V3, a little bit in V4 and 5. But that ST elevation is associated with another concerning sign, which is the tall R wave, in particular in V3 here. The R wave, the height of the R wave in V3 is even a little bit more taller than V6. And if you look for the T wave, it's upright here. And this is actually what we are calling the mirror image for posterior STEMI. As we know, the traditional 12 lead ECG are not looking well for the posterior surface of the left ventricle. So we are looking at the anterior, inferior, lateral surface, and a little bit to the right side of the heart, to the right ventricle. However, the posterior surface is not completely captured in that 12 lead ECG because we are not representing, we don't have any contiguous lead for the posterior ECG. So we are depending on seeing what's happening in the posterior surface on what we name the mirror image in the anterior surface. So it will be flipped. If we look at the anterior surface, like V2, V3 as in the previous ECG, we will see that picture. ST depression, tall R wave, and upright T wave. And if we flip this image as looking at a mirror, that will give us with Q wave, clear ST elevation, and inverted T wave, which are the classic pattern of ST elevation myocardial infarction. So please don't be fooled again by that ST depression in the anterior lead as being as a non-STEMI ECS. It could actually reflect a true isolated posterior STEMI. And to confirm that diagnosis, we will have to add extra lead, extra posterior ECG by moving our V4, 5, 6 leads over the posterior surface of the left side of the chest, in parallel with the posterior axillary line, mid-scapular and paraspinal line, and then repeating our ECG, and that side will be additional posterior ECG. And in this condition, our threshold for diagnosing ST elevation on the posterior surface of the heart will be only 0.5 millimeter because we are recording and we are getting the electrical activity through the bulky muscle of the back. So it's not 1 millimeter, it's only 0.5 millimeter of ST elevation. So what's the really unique, what's really characteristic for posterior STEMI? It's actually the least common site for the left ventricle to have myocardial infarctions. It represents only about something 3 to 10% of the infarction. However, it's mostly accompanying other surface STEMIs, like inferior or lateral infarction. So it will be more common with the inferior and the lateral infarction. So if you have someone with infraposterior or lateral posterior STEMI, you are going to treat him as a STEMI, and this is good. However, if it's isolated without inferior, without lateral, it can be easily overlooked and it will be really missed. And that's why this is the most missed STEMI pattern or ischemia. It's about Only 30% of patients with isolated posterior STEMI are revascularized within that critical time of 90 minutes. And posterior extension means larger infarction size, and that will be associated for sure with higher risk of left ventricular dysfunction and death. So isolated STEMI is very risky. Outcome of this patient, fortunately, this patient was pegged, posterior ECG showing ST elevation in the posterior leads, and he was sent directly to the cath lab, and there was about 95% again lesion in the distal LCX, left circumflex artery, and he was alhamdulillah, fortunately, successfully stented with favorable outcome. So let's go for third case, and this is a very interesting one that I have seen myself at our Tanta University Hospital. So this one is 48 years old male, smoker, presenting with chest pain, and he was referred from a district hospital directly to the cardiology service. I'm assuming that the doctor that assessed the patient in the district hospital wasn't comfortable for the patient presentation. He looks ill, he looks sweaty, and that story of his chest pain looks critical, looks typical for cardiac sounding chest pain. However, he couldn't find a cause in the ECG to activate the cath lab. So instead of sending him to the ED, he decided it will be safer to send him directly to the cardiology service. However, in the cardiology department, because of busy area and it wasn't a STEMI, it wasn't referred as a direct STEMI case, so the patient was redirected back again to the emergency department, and this was his initial ECG at our ED. And I will keep it for 1 minute, and then I am going to ask you the next question. So for that story, I told you, what would your next step? Would you activate the cath lab for this patient, or you will keep the patient in your ED starting to treat him as ischemic chest pain, non-STEMI ECS, or looking for other causes of that chest pain? So till now we have 100% patient. We are going to activate 100% of our participants will go for cath lab activation. Now it's getting a little bit lower, 94%. I will get you extra time to change your mind if you are going to activate or not activating the cath lab for that patient with that story and that ECG. Because, activating cath lab, this is such an invasive procedure, costly procedure. So if you are going to do that decision, take that decision, you should have a good rationale on a well-based evidence. Otherwise, you are going to be blamed anyhow. So, okay, now it's more than 80% or less than, okay, let's say 80%, 80-20. 80 you are going to activate the cath lab, and 20 we are not going to activate the cath lab. What we are looking here, actually, is there is any ST elevation? The answer will be no. There is no ST elevation in that patient. But we are looking for one kind of hyperacute T wave. If the T wave is hyperacute, tall and peaked like that, it's the height like rule of thumb. Its height is similar or even bigger than the preceding R wave. This is called the hyperacute T wave. And this pattern is known as the De Winter T wave, is a sub-pattern or subtype of hyperacute T wave. But it's also associated with another characteristic finding here, with is upsloping ST depression. So that ST wave is completely depressed, completely lower than the baseline of the TB segment. And here the J point, it's completely is a little bit far away, lower than the TB line. So this is ST depression, and that ST depression is upsloping in pattern. It's not transverse, it's not convex up, it's upsloping, followed by hyperacute T wave. And this is in particular in the pericardial lead, starting from V2, V3, V4, and V5 a little bit. So this is as described as the De Winter T wave, and it was first described in 2008 with the cardiologist Dr. Rupert De Winter from Netherlands, and it was cohort. It was study cohort including more than 1,500 patients with acute lead occlusion, and 30 patients from this cohort. It represents about 2% of the lead occlusion patient have that coronary artery pattern, or have that ECG pattern, and all the 30 patients 100% has proximal lead occlusion on angiography. This is a very, very high-risk ECG pattern that have been now included in most guidelines as a STEMI equivalent, and you should activate the cath lab for it, and you should be treated as a STEMI. So what about the outcome for that patient? Few minutes later, after getting that previous ECG, the patient went into VTAC, witnessed cardiac arrest. He received a DC shock and CPR, and fortunately, he achieved ROSC within few minutes, and voila, this is her second ECG after achieving the ROSC. Now you can see it clearly. This is an extensive anterolateral ST elevation getting about to the shark fin sign or tombstone appearance. So this is again an extensive anterolateral STEMI that should be treated from the first time as STEMI or even extensive one. So that's why I'm talking about, it's not about STEMI. So occlusive myocardial infarction doesn't mean all the time having STEMI pattern in the ECG. And this is guide us to the latest evidence. One meta-analysis published in 2024, including three bold retrospective study with more than 23,000 patients with suspected acute myocardial infarction, and the diagnosis of acute coronary occlusion was confirmed with angiography. And in this study, they tried to compare the diagnostic performance of STEMI versus OMI criteria. And what we have found that the sensitivity is jumped. If we are using the OMI non-OMI strategy, jumped from 43% to 78%. However, the specificity was almost maintained the same. So we get better sensitivity with maintaining the same high specificity. So I will keep you with this rapid list of STEMI equivalent pattern that included in either 2022 ECC expert consensus and the same for 2023 ESC guidelines for the management of acute coronary syndrome. So every time you are looking for that ECG, it's not about the STEMI alone. You should consider both STEMI equivalent and also the STEMI mimic. So missing STEMI is very bad. But on the other side, overactivating cath lab for non-STEMI or non-OMI patterns is also costly. And that lead us with one study that we have published recently accepted as a poster in the ISEM 2026 conference, trying to find the physician diagnostic accuracy for both the STEMI equivalent and the STEMI mimics. And here's the result. Posterior STEMI or isolated posterior STEMI with at the bottom of the list, and subtle inferior STEMI with the third one from the low, and De Winter pattern, as you have been guessed, was fortunately better recognized. So it's not about the ECG alone. Don't stick to STEMI definition all the time. Look for other OMI pattern. And if you are confused, seek for expert opinion. Thank you, everyone. And this time for question, I will be happy to receive your all question in the Q&A section. And thank you for listening.
Thank you very much, Dr. Muhammad, for this exceptional presentation. And first of all, congratulations for promotion to assistant professor.
Thank you,
a very good step, and we really appreciate your support for emergency medicine, not only in Tanta, but all over the country. My quick question for you, even your presentation was great. When, as you are the first one to see the patient in the emergency room, when you call for cardiology, when you involve the cardiologist in the process of the management?
So it actually depends on three pillars of assessment. It's about the patient history, examination, focused examination, ECG, and cardiac markers. So sometimes the ECG is completely straightforward. We have that clear STEMI story, clear STEMI definition, clear STEMI criteria in the ECG, and that patient will directly go for the cath lab if it's available, or starting reperfusion. And for reperfusion strategy now in more than EDs, it's started with the ED physician. Sometimes, which is the problem here, sometimes the story is not clear, straightforward. Sometimes you will try to find more clues, not only the ECG. the cardiac markers, serial ECG, repeating ECG, doing point of care ultrasound, looking for echo assessment of the heart, and that should be done. But anyhow, whatever you have, you are concerned about the story of the patient, the clinical assessment, hemodynamic, electrical stability of the patient is also very important. Whatever you are, you are concerned about the possibility of having ECS, we should start treating the patient at the ECS, putting on the cardiac monitor, oxygen supplementation, starting dual antiplatelet, and call for the cardiology for that. And also, we are not calling the cardiology only for ECS, massive pulmonary embolism. We have the BERT the BERT team now should be integrated early in the management of such patients. So it depends on the presentation, actually.
Thank you, doctors, for the valuable presentations. There is a question for Dr. Nasreen. Dr. Nasreen?
Hi, Amjad.
Hi. Someone asked, what is the ER sepsis bundle that you recommend for to follow or to create in the emergency department?
So let's be clear, a bundle that will work, it will be a bundle that will be triggered by the nurse, by the triage nurse. So it should be an easy tool for the nursing working in the triage to activate the bundle. Let's start, for example, of any tool used in your triage. I don't know if you use the CTAS, for example, the Canadian Triage Scale, or the Emergency Severity Index. There will be some criteria missing in this tool to trigger the 1 hour bundle that must be activated for any septic shock in the ER. So what we are using actually, and we have demonstrated in our ER with a paper that will be published in the European Journal of Emergency Medicine, that with incorporating the NEWS2 parameters, we will be activating very fastly a 1 hour bundle to detect all the septic shock that will be presenting to the ER with a high impact on the mortality. So let's start by implementing any bundle that the nurses could easily be using to detect the signs, the early warning signs of the septic shock.
Thank you very much.
Another, Dr. Hakim, تفضل.
Thank you very much, Dr. Nasreen. Again, the question for you, because actually I'm working in the field of the trauma and the use of vasopressors. So septic shock diagnosis and the use of vasopressor, if you kindly just clarify this point, this will be very helpful for the management of shock, especially the septic shock. Thank you.
So thank you for your question. So according to the newest recommendation, we should start by the norepinephrine. We will be introducing very quickly the noradrenaline to start with. When escalating the dosage and we found that our patient is still not responsive to the escalating dose, we will be starting adding other vasopressors to the norepinephrine. Okay, but as I was mentioning in the previous presentation, we should dynamically assess the variation of the stroke volume variation and the lungs, the heart, to see what vasopressor could be added to the norepinephrine to get the maximum results for our patient. So we start with boluses of fluids. We reassess our patient, the responsiveness for the patient. We start very quickly the norepinephrine, the noradrenaline, and then when the response is still not adequate to our target, we can add the vasopressor to our norepinephrine.
Thank you.
Thank you, Dr. Nasreen. Another question for Dr. Muhammad. Is there any coronary artery occlusion which needs immediate attention? I don't think if the question is clear.
Yeah, for sure, any complete coronary artery occlusion need attention, but the question is maybe is needing for cath lab activation or not, and that will be different. It depends on the level of occlusion. If we have any patient with OMI, occlusive myocardial infarction pattern, yes, that should be referred for reperfusion strategy depending on the availability, either invasive one, primary PCI, which is preferred, or starting pharmacological reperfusion with thrombolysis depending on the availability and the time.
Thank you, Dr. Muhammad.
Thank you.
I think we will run out of time, Dr. Amr.
Thank you so much,
Thank you.
everyone, for your contribution. Thanks, Dr. Amjad Mahour, Dr. Hakim Al-Kholi, Dr. Muhammad Nasruddin, Dr. Hind Mansour, and Dr. Nisreen for the great presentation and moderation. Again, by tomorrow, everyone should get the YouTube recording so you can hear the lectures over and over, because I think one time is not enough to get this heavy meal. So by next week, all attendees should get a certificate of attendance. And if you are interested to join our resuscitation and emergency medicine diploma, please go ahead and take advantage on the 10% discount. We already shared the application, the registration, and the diploma landing page link. So if you are interested, please go ahead and If you have any questions, please reach out to me or to any of our board members, including Dr. Haitham Khalifa, Dr. Wissam, and all of our speakers, contributors, panelists, and tutors. With that, I wish a happy rest of your day, your afternoon, your evening, your night. Bye.
Bye, everyone. Assalamu alaikum.